Hey everyone, this is a recorded lecture on infectious respiratory conditions. I have some that are more common that we'll talk about that you may possibly even see in your pediatric clinical. So it just gives you a good place to start as far as some of the more common conditions that you need to be aware of. Just remember, and I tried to include this on each slide, make sure that you understand what the condition is, what are some risk factors for that condition, what are some common signs and symptoms that you may see or hear from the parent or the patient about, what are some common treatment methods, and then maybe some common patient education tips. Okay? If you have any questions, again, write them down, bring them to class, or shoot me an email. So the first condition that we're going to talk about is acute bronchitis. You will see this in pediatrics and adult. This is actually a fairly common diagnosis that you will run into. People will come in with these signs and symptoms all the time, especially I would say during the months of October to May. That tends to be the more common time when acute bronchitis will be seen. So one thing important to note is that acute bronchitis can be viral or bacterial. So you can see on the slide I've included some common pathogens that you may find, and I also separated them into viruses and bacterial. Some other common non-infectious offenders can include allergens. So that one may be seen more so over the spring, summertime. But tobacco, smoking, toxic fumes, pollution, those can all cause an acute non-infectious type bronchitis as well. So one thing to be very clear about is that current guidelines caution against antibiotic use in patients with acute cough in the absence of pneumonitis by imaging. So that means by chest x-ray. And one reason why I make sure that I tell you that is because it is inevitable. You will have parents come in and their child is having a persistent cough, and you may notice even that they just aren't quite as active, and the parents will demand an antibiotic. However, on your exam and with the history that you're gathering, you are pretty sure that this is viral. Say the symptoms have only been going on for a couple of days, which makes you even more likely to suspect that it's a viral-based infection. You will find that you are going to have to stand your ground and educate that parent or that patient on why an antibiotic will not be helpful in a viral condition. So just make sure, especially if you do end up going into pediatrics, that's where you tend to see that most because parents come in and they're nervous. But just make sure that you understand why you are not prescribing an antibiotic for a viral infection, and then make sure that you can explain that to your patient. That will help you so much. So signs and symptoms. So if you're looking at it subjective versus the physical exam. So for subjective, you're going to hear about this cough. It's typically the predominant complaint for this type of upper respiratory tract infection. The cough can be productive or it can be non-productive. It can be either one. Sputum may be clear or it may be colored. You can hear of colors ranging from yellow to green. And it may be accompanied by a sinus congestion, a runny nose, or a sore throat, but not always. It may just be this persistent cough. So on physical exam, because we're always going to do a physical exam on these patients, fever is typically unusual, so you'll find that that's normal when their vitals are taken. However, if it is related to a virus like influenza or the rhinovirus or the coronavirus, any of the viruses really have a high propensity of causing fever, especially in children. So just keep that in the back of your mind. Lung exam may reveal rhonchi or wheezing, but typically there's no crackles or evidence of a lung consolidation. If you would hear crackles, especially in the bases, then you would be more concerned for a bacterial infection. And at that point, I would say probably a chest x-ray would be warranted so that you can rule out pneumonia. So some of the differential diagnoses of an acute cough, so just some other things that you may need to rule out. You don't always want to just automatically diagnose a patient with acute bronchitis, but you want to make sure that you're looking at all different angles. So you want to make sure they're not having a subclinical asthma exacerbation or a bronchospasm. You want to make sure that maybe they don't have a postnasal drip going on, allergies. This is very common from May to October, so kind of on the opposite side of what we talked about originally for acute bronchitis. You want to make sure they don't have any pertussis, or if it's an older person, congestive heart failure, although that could be in a child too. And then you want to make sure they don't have any reflux disease, a neoplasm. You want to make sure that it's not related to ACE inhibitor use. And then, of course, like what we just discussed, you want to make sure that it's not related to a pneumonia that's hiding there. So if you suspect that this acute bronchitis is related to a bacteria, then you can start discussing antibiotic use. Typically, guidelines, the first line is azithromycin, and then from there you can look at possibly using some of the penicillins for children, and then the fluoroquinolones. Although the fluoroquinolones you have to be careful about in older adults, as some of the side effects are not necessarily wanted side effects. And again, for viral infections, you want to try to refrain from antibiotic use. So then what you're going to do is you're going to look more towards symptom management. So if somebody is having a postnasal drip or sinus congestion with this, maybe you can look at using like a Flonase to help decrease some of that inflammation on their turbinates, or you can talk about a nasal saline flush. Humidified oxygen if people are struggling, or maybe if it's an adult and they're already on oxygen, you can add some humidity to it. You can look at nebulizer treatments, things like that. So you want to focus more on symptom management. I got ahead of myself a little bit here. So this is another slide on acute bronchitis. Some of the other conditions here, I just have one slide, but acute bronchitis had a lot of information. So I kind of split it into two different slides. So general consideration. So if you have recurrent bronchitis, and this may be seen often in your patients that have a chronic bronchitis type COPD, you really need to make sure that you also are ruling out asthma or acid reflux disease, cancer, or a postnasal drip, because these are all things that need to be dealt with separately. So just kind of keep that in the back of your mind. If they have abnormal vital signs such as a low pulse ox reading, then that would be a time to consider a chest x-ray to rule out pneumonia. And then always remember, if you have a patient that just really looks like they are struggling and you're concerned about them going and, being home, especially if it's an older adult and they're living by themselves, you can always send them over to the ER for evaluation. If you think that they're possibly on the border of needing to be hospitalized, there's also the MedCalc app in your phones. You should be able, I think Androids, I know I have an iPhone, but Android users also can download this app. But there's lots of different scales that you can use to see if it would be appropriate for them to get evaluated for hospitalization. And I always use those, and I add those to my notes so that people know that I did consider them going home versus hospitalization. However, according to this scale, it shows that we need to at least do a little bit further investigation to see if they need to be hospitalized or not. So again, some indications for antimicrobials would be pertussis or seriously ill patients, especially if they're older than 65 years of age, if they have multiple comorbidities. So if you have somebody that has severe COPD, more than likely they're going to have to be treated inpatient or at least put in observation unit to monitor them. So keep that in mind. And then for viral bronchitis, like we said, you just want to consider symptom management medications. So you can look at the different types of cough medications that are over the counter. If they're having a lot of pain, a real bad sore throat, you could consider adding codeine, although I try to avoid that just because of abuse issues that, around in our area we're having. If there's an allergic component, you could consider adding an antihistamine like loratadine or sertrazine. You could also consider adding an NSAID for comfort. However, make sure with older patients, and I know most of us know this, but just make sure with older patients, if they have a history of any sort of gastric ulcer or gastric disease, you want to try to avoid those NSAIDs. Also in kidney disease as well. When I have a person that comes in with acute kidney injury into the hospital, one of the first things that I look for is NSAIDs, and I stop them right away. So just keep that in mind. And then, like what we were kind of talking about earlier, bronchitis can be a chronic condition. So if you have someone that has gone through and they've been diagnosed with COPD and it's more of a chronic type bronchitis, make sure you follow the gold standards, and that PDF is included in your module. One thing to make sure on exam is that you need to make sure if sinusitis is involved. You need to know to what degree and how long it's been going on. If it's present, depending on how long the symptoms have been going on and what you see on exam, you may want to add an antibiotic for that. If it typically, for me, I usually look at if the symptoms are just, they're getting worse, they're hard for the patient to deal with, and or if the symptoms have been there greater than 5 to 7 days, then I typically will order an antibiotic for them. So call for bronchospasm. You could also consider an albuterol inhaler or nebulizer, depending on what is easier for the patient and depending on what they have at home. And then for a longer lasting control of bronchospasm, you could consider adding Singulair daily during the times when exacerbations occur more frequently. So lots of different options for this. Next one we're going to discuss is pertussis, and I'm sure the majority of you have probably heard of this. So pertussis is a very contagious disease caused by a type of bacteria called Bordetella pertussis. This bacteria attaches to the cilia that line the upper part of the upper respiratory infection. On this slide, I include the 3 stages of pertussis, and so the main thing to know is that symptoms typically last about 6 to 10 weeks, and then the paroxysmal time is typically when people are the most able to pass along this condition. So the World Health Organization estimates that 60 million cases of pertussis occur worldwide on a yearly basis. Pertussis can also make a person, especially young children, more prone to pneumonia, sinusitis, nosebleeds, scleral bleeds, and otitis media. So hearing that information, one thing you need to make sure is that when a person comes in and you're suspecting pertussis, it may not just be pertussis. They may have multiple things going on. So the big thing to do is to make sure that you are doing a thorough physical exam and you're getting a good health history so that you can treat them appropriately. So transmission of disease can occur during the catarrhal stage and then during the first 2 to 3 weeks of the paroxysmal phase. So vaccination against pertussis should be encouraged among children according to the current CDC guidelines. So typically, the DTaP, as we call it, the DTaP vaccine or the Certiva, it'll cover diphtheria, tetanus, and pertussis. And I would say, in the U.S., the amount of pertussis that we're seeing has diminished, although since more people are starting to refuse vaccines, we're noticing that there is a little bit of an increase in pertussis. Overall, compared to third world countries, though, I would say we have seen a huge decline since we've been using this vaccination. So that is an important part. A lot of these people, especially, parents I'm talking about, when they come in, they have, they've been influenced by the media. They've read a lot of blogs and different things like that. I think one of the biggest things that we can do to help promote vaccination is not necessarily promote vaccination itself, but we need to be understanding and we need to be supportive of the fact that they're trying to be the best parent that they can be. I think a lot of the times they expect providers to attack them because they don't want vaccinations, and I think that's probably one of the worst things that we as providers can do. We need to show them that we are on their side and that we understand that they're wanting to do what's best for their children. So it's our job to give them all of the information that they need to make a good educated decision. And hopefully, if you take that approach and you give them the education that they need, hopefully they'll understand the importance of vaccination. Another thing that I have found that works with parents, and the provider that I followed for my pediatric rotation did a really good job of this. He had multiple options. So if he found out that they really were more concerned of how many vaccination and injections, it usually was injections because they hate seeing their kids get hurt. But if that was more of the issue, was that they didn't want them to get all of them at once, you can offer them other options as far as spreading the vaccinations out. So at least the kids are still getting them, but you're coming to a compromise with the parent as far as when they're actually getting them. So just keep that in mind too. So a sputum PCR swab is usually used to detect the Bordetella pertussis in individuals that have signs and symptoms, so keep that in mind. And then treatment, so the first line is erythromycin, although erythromycin does cause a lot of GI issues. So a lot of people, what they're finding is moving on just to the second line, which is azithromycin, but both of them can be used. So some alternatives can include Bactrim DS or clarithromycin. I don't think clarithromycin is used as much anymore, more so because of the side effects that it can cause. It causes a lot of GI upset as well. So typically we tend to see Bactrim DS and azithromycin used. Some other patient teaching tips I've included in the notes section, so make sure that you download this PowerPoint and look through those. Some of them include watching for dehydration, because these children will cough a lot. They more than likely won't want to eat a whole lot, so dehydration is always a concern. You can use cough suppressants if needed. You want to encourage adequate hydration. I know my kids, whenever they've gotten sick, they've obviously never had pertussis, but whenever they get sick, they really like Pedialyte. And I think a lot of kids, there's lots of different flavors. So I think a lot of kids, that's kind of a treat for them, because it's something that is sweet, and it does really help fight against dehydration. So it's kind of a win-win for the parent and for the kids. So just keep that in mind. Next condition we'll talk about is influenza. So typically this is an acute illness. A lot of the times it's just self-limited. The people that really end up having a lot of issue with influenza are ones that are immunocompromised, or the ones with multiple comorbidities, or the very young or the very old. So those are the people that typically need a little bit more need a better watchful eye, basically, to make sure that they are able to tolerate their symptoms okay. So incubation is about 1 to 4 days. Infected persons are most contagious during the peak symptoms. So what this means is that when their symptoms are the worst, that is when they are the most contagious. And so we need to make sure that we educate our patients about that. So influenza is a droplet disease, meaning that it's spread by droplets with the respiratory secretions. So risk factors just to be aware of are crowded environments, and so this can include nursing homes, schools, correctional facilities. So these are the people when they're coming in that if they're coming in with some respiratory symptoms, some GI symptoms, we need to make sure that we're testing them. Non-vaccinated patients, and then immunocompromised. So when a person comes in, some of the more common subjective complaints may be that they're just saying that they're just tired. They don't feel like getting up. They just feel like sleeping all the time. They may have a cough. They might not be able to cope with their daily activities. Some of them say that they just cannot get out of bed. A lot of the times you'll see a sudden onset of a fever, and a lot of the times this is greater than 101 degrees. So I'm sure you guys have seen these too, but they can have some fairly high fevers with the influenza virus. A lot of the times they don't feel like eating, so they're anorexic. They have chills, sweats, headache, possibly a non-productive cough, runny nose, nasal congestion. So, and then when you are looking towards the physical exam, there's not really any specific findings for influenza. However, it's really important to make sure that you do a thorough HEENT and respiratory exam, just to rule out any conditions that might also be presenting with the influenza, such as sinusitis or otitis media or pneumonia. For diagnosis, really, a lot of the times, especially for older patients, you want to do a CBC and you want to do a CMP if you're concerned about dehydration. Some of the older patients, if they really aren't eating or drinking well, they could go into a little bit of a mild acute kidney injury. So you want to make sure that we are keeping our patients hydrated. You can do a CBC. Typically, they'll have a normal white blood cell count, or they might even have a lowered white blood cell count, or the leukopenia they might have. A rapid influenza PCR, which is a swab, you can do that to show a positive influenza, and then a chest x-ray if indicated. So if you're thinking that there might possibly be a pneumonia in there as well, then I would say go ahead and do that chest x-ray. So one important thing before we start talking about treatment is the vaccination. Our ultimate goal with influenza is we want to try to prevent as much as possible. So all persons greater than 6 months of age should really be encouraged to receive the flu vaccine annually. Women who are currently pregnant should receive the inactive influenza vaccine. So there's lots of different options for people to receive this vaccine. We all know that, they create the vaccine from the year prior. So sometimes a vaccine you'll see works a little bit better than other years. However, what I always do is I always encourage people is, even though that is the case, if they don't get the vaccine, they could have a worse illness with the influenza or a longer illness trajectory with influenza if they don't get the vaccination. So the vaccination should at least make their condition more mild if they do end up contracting it. So with influenza, typically we're focused more on symptomatic treatment. And so you can encourage people to do the saline nasal sprays. They can do an analgesic gargle. They can use Tylenol, ibuprofen. They can use a cool mist or an ultrasonic humidifier. If they're inpatient, we typically put them on a droplet precautions. Even though they won't necessarily be able to do this at home, what you should encourage is that they just kind of steer clear of other people for a little while until their symptoms are improving. That way they don't spread their virus around to other people. So if we end up using antivirals, typically we want those within 48 hours of the symptom onset. And these are typically recommended for high-risk people that are at high risk of complications. So people with diabetes, COPD, asthma, CHF, all of that. And then antivirals are typically always recommended for hospitalized patients because if we're hospitalizing them, then they're sick enough that we need to consider those antivirals. So antivirals do not cure influenza per se, but they shorten the length of the sickness. And so that's something for people, for patients to be aware of. Tamiflu is the first line. There is renal dosing available. So typically what I end up prescribing for people when they come into the hospital or high-risk persons, it's 75 milligrams twice a day for 5 days. For renal dosing, typically we do 30 milligrams twice a day for 5 days or 75 milligrams daily for 5 days. For people with renal issues, you don't want to go over 75 milligrams per day. Tamiflu should be taken with food as it can cause nausea. And then in children, we have to make sure that the Tamiflu, and pharmacy can do this for you, the Tamiflu has to be dosed by their weight. And again, we can use Tylenol or ibuprofen for symptom management as well. You always want to encourage your patients to stay hydrated, so encourage fluids. You want to encourage rest. You can tell them, our body needs time to heal, and we do that while we're resting. And then you can just follow up as appropriate. Next one is bronchiolitis. This is one that you will see that is very common with children. My kids have had it multiple times. Typically, the most common pathogen is RSV. So a lot of the times you'll see kids with this during the months of October to May. It's not always it's not a fun condition. And so, just keep in mind that a lot of patients, when they come in, their parents are very, very concerned, and rightfully so, especially if a children has asthma as well, it's going to cause an exacerbation of their asthmatic symptoms. And, so parents are going to see their kids struggling to breathe. And so a lot of the times this is just you teaching the parents and helping them calm down. So offering that support. So bronchiolitis is the inflammation of an obstruction of small airways and reactive airways, generally affecting infants and young children. So as we said, the common pathogen is RSV. I've also included some other ones on there. Treatment a lot of the times consists of symptom management. So supportive therapy may include upper airway suctioning, nebulizer therapy, and then, of course, prevention of dehydration. So with any of these upper respiratory infections, that's always a concern that our patient may get dehydrated, especially children or older adults. So always keep that in the back of your mind. Some other commonly associated symptoms that these patients may have are conjunctivitis, pharyngitis, otitis media, and then they can also have GI symptoms like loose stools. So just keep that in mind. Bronchiolitis is the leading cause of hospitalizations in the U.S. It accounts for about $1.7 billion in healthcare costs. And like I said, it's usually seasonal, so mostly during the months of October to May. Typically, you'll see this in newborn children to 2 years of age, and then it occurs more often in males versus females. So risk factors, and this is an area to make sure that you know well so that you can also provide patient education to their parents. So risk factors include secondhand smoke, low birth weight, premature birth, immunodeficiency, babies that are formula fed versus the breastfeeding, contact with infected persons, children in daycare environment. And I will tell you, when I first had my daughter, we had a nanny for her. So she stayed at home and the nanny took care of her at home. And then when we moved to Illinois from Ohio, I started sending her to a daycare, and I think I was well, I know I used all my PTO days at work because my daughter had never been more sick than she was that entire year. So just keep that in mind. Children in daycare have a high probability of catching more conditions than children that are kept at home. And then congenital cardiopulmonary disease. And then if they're less than 12 weeks of age, they're always susceptible to more of these conditions than some of the older children. So some of the signs and symptoms that you may see, they may be irritable, they may have some anorexia going on, fever, typically it's greater than 102 degrees Fahrenheit. They may have a noisy breathing, you may hear parents talk about that, coughing, little babies may be grunting because they're trying to breathe, they're struggling, possibly some cyanosis, apnea, vomiting, tachypnea, retractions, runny nose, wheezing. All of that can be seen with bronchiolitis. Some general prevention measures. You want to encourage parents and people taking care of these babies to be, or these children to frequently wash their hands. And you want them to use an alcohol-based hand sanitizer if that's what they're using to wash their hands. Contact ISO of infected babies, or at least keep them away from sick people, kind of keep them, we don't want them to pass anything along, so keep them away from other children. And then encourage breastfeeding, because breastfeeding is actually preventative in this. The Synagis vaccine, that is a vaccine that is given to prevent RSV. It's typically given between the months of October to May, normally administered monthly. This is only given to high-risk patients only. So patients that are at high risk for contracting RSV, or if they would contract RSV, it would be detrimental to their health. These are the children that are going to get that vaccine. As far as treatment, again, like I said, it's mostly symptom management. You want to make sure that the patient is able to breathe appropriately. Laboratory testing is not necessarily required, but you can test for RSV to see if that is positive. If you are concerned about a pneumonia, you can do a chest x-ray. You can use humidified oxygen, nebulized hypertonic saline, and then if you are suspecting a bacterial involvement, then you can consider use of an antibiotic. Next condition is tuberculosis. One thing to note is that tuberculosis, one is really is a separate specialty. So your infectious disease providers are going to be the ones more so taking care of these patients with tuberculosis, because it is the treatment involved for tuberculosis is is just that. It's very involved. There's a lot of strict follow-up, a lot of side effects from these medications. So just keep that in mind. If you have a patient that comes in with a tuberculosis and they are diagnosed tuberculosis, they if they're active disease, we need to get them out of that active phase. So a lot of the times they will be hospitalized and put in isolation. If they are in a latent phase, more than likely they're being followed or need to be followed by an infectious disease doctor. So I just included some general information about tuberculosis up here. So one important thing is to note that there can be pulmonary tuberculosis or extrapulmonary tuberculosis, and what that means is that they can primarily have pulmonary symptoms or symptoms outside of the pulmonary system, and I'll go over that here in a second. So an estimated 9 million new cases of TB occur yearly worldwide, and so a lot of the times we don't see a lot of TB in the US, and we're very fortunate for that fact. However, in a lot of the countries outside of the US, they still experience high numbers of tuberculosis. When I lived in Chicago, they actually still had a decent amount of TB that would occur. So we actually had quite a few rooms for negative pressure isolation just for that fact. So just because we live in the US doesn't mean that you don't see it. So just keep that in mind. So in the US, TB primarily affects HIV-infected individuals, immigrants, the elderly, and disadvantaged individuals. So disease from a patient with pulmonary TB is spread by droplet nuclei that are aerosolized by coughing, sneezing, or speaking. And then TB is infectious during its active stage. So some of the risk factors that you're looking at, recent acquisition or contact, comorbidities, malnutrition, tobacco smoking, and then presence of fibrotic lesions in the lung. Signs and symptoms, they're typically non-specific at first. A board question though, and I know we talked about this in our second lab day. Whenever somebody says that they're having night sweats, you have to roll out TB. That is going to be a board question, so just make sure that you remember that. They can have a non-specific fever. They can have weight loss. Typically, you'll find that this is greater than 10 in 1 month. And I wrote that wrong on the slide. So it should be greater than 10 pounds in 1 month, and they're not trying, okay? They're going to be dealing with some anorexia. They're going to be tired. They're going to be weak. These are all some just common non-specific signs and symptoms of TB. So for screening, and I'm sure all of you have had this done, there's always the skin testing. Or if you've had a positive skin test in the past, or if you know that you've had contact with somebody with TB, they typically will do a chest x-ray. There is a vaccine, and that is suggested for high-risk populations, and that's something that is individualized for each patient. So when we're talking about pulmonary TB, frequently that's located in the middle to lower lobe, so that's where you would see it on a chest x-ray. And then progressed disease symptoms of the pulmonary TB, that would include cough with a purulent sputum. Typically it's blood tinged. And then on a chest x-ray, you'll see extensive cavitation. For extrapulmonary TB, it can be any site in the body outside of the lungs. And I think it was an episode of Grey's Anatomy one time. They had a patient that had been traveling and came in and had a bowel obstruction. And it was supposed to be a routine bowel obstruction, but the patient came in and they were in the middle of surgery, and they saw some blood tinge streaking on the intestines, and ended up come to find out they had extrapulmonary TB of the bowel. And so everybody in the room was had a higher probability of being infected because they had opened the body up. So then they all had to be desensitized and all this, and all of that. So that, I think that was in one of the Grey's Anatomy episodes, but that it's not as common, but it can happen. So some of the common sites include lymph nodes, the pleura, the GU tract, the GI tract, bones, joints, the meninges of the brain, the peritoneum, and the pericardium. Typically, you'll see extrapulmonary TB in HIV patients or immunocompromised patients. Signs and symptoms it depends on what system is affected, but you can see anything from painless swelling of the cervical, supraclavicular nodes, straw-colored pleural fluid with elevated protein levels. They can have urinary frequency, dysuria, kidney lesions, hydrocephalus, intracranial hypertension, intestinal obstruction, or pericarditis. So really it depends on what system is affected. So for a diagnosis of TB to be definitive, the diagnosis requires growth of the M. tuberculosis in culture or identification of the organism's DNA in clinical samples. And then some treatment concerns is when you are working a patient up for a possible diagnosis, especially in the U.S. here, because a lot of the times, because we don't have a high rate of tuberculosis, the tuberculosis, when people do have it, we find that it's multi-drug resistant TB. Those are the ones that are kind of sneaking into the U.S. So keep that in mind. Another thing with treatment concern is compliance. Like I was saying at the beginning of this slide, a lot of the times these patients end up seeing specialists that deal with TB because there's a lot of side effects with these medications. There is compliance has to be there because they will flip over into an active state fairly easily. It's just like an HIV patient where they have to be very compliant with their medications and be followed up more frequently. Same way with TB. So a lot of the times they offer incentive for these patients that are receiving treatment, or they hospitalize them for them to be treated and to be removed from the active stage before they're released. Drug cost is always a concern, and then drug side effects. So that's always something to keep in mind. For the treatment, if you look at that last box on there, I did put up some of the first line and the second line. There's also third and fourth line as well. One thing to make sure that you're aware of is a lot of the times they will combine a first line drug with a second line drug. And especially for patients that are multi-drug resistant, they end up having to be creative and they have to give them multiple drugs rather than just one. So the biggest thing here is just when you have a patient that you're suspecting TB, a lot of the times they end up needing to be hospitalized during that time while you're waiting to see if it is for sure positive TB. That also gives them a chance to see a specialist when they are inpatient. You can have infectious disease come and see them. That concludes our lecture on infectious respiratory diseases. Again, if you guys have any questions, write them down, bring them to class, or shoot me an email and I will get back to you as soon as I can. Thanks.